All right, everybody, welcome back. We are now going to get into talking about neurological emergencies and seizures. This is going to encompass everything: altered mental status, stroke, seizure. We'll talk a little bit of head injury just in general. A lot of that saved for the trauma lecture itself, but we'll get into the little bits and pieces here first and foremost. So we've learned how to figure out a patient's level of consciousness, right? We've done all of that AVPU and the conscious, alert, and oriented questions. We know that these folks need to be able to answer to us who they are, where they are, roundabout what time it is, and pretty much what's going on. And we haven't really talked a whole bunch about what's going on and what it means and how we can sort of figure out where their altered mental status might have started or how their altered mental status might have started. And that's going to be where we get into actually talking about some of the common causes and things that we can do to assess and not really treat, but at least figure out, is there something more at play here, and is there something more that I could be doing? We'll talk about seizures and sort of the causation and what's going on with our patient, and more importantly, what's not going on with our patient, because that is far and away a much bigger deal. What isn't happening is really what's making our seizure patient sick. So altered mental status, great big wide ranging blanket term that is any change in my patient's level of awareness, level of consciousness, anything that makes this patient different mentally from what their average everyday is going to be altered mental status. This is far and away one of the more common things we get called out for. And it could be anything from a patient who is just confused. It could be a patient that is totally unconscious, unresponsive. Yesterday, some of you guys worked through station 1 with me today. The rest of you will be going through station 1 with me later. Your patient who was dead on the floor in aisle 2 of the market basket or Stop and Shop or in the parking lot of some other form of local establishment, guess what? They're altered because they're on the ground, unresponsive. Clearly, they have bigger problems, but they are, until you get to the point of assessing pulse and respirations for 5 to no more than 10 seconds and finding out that, holy smoke, they're not just altered, they're actually in cardiac arrest. Right at that very given moment in time, they just have an altered mental status. Confusion, a patient who's confused, could be from any one of a number of things. It could be actual disease process. It could be hypoxia. It could be a patient who is under the influence of some sort of mind-bending substance. You never really know. And then lastly, the bit that we're getting into, a post-ictal state. Seizures happen in very predictable fashion. The patient will have the initial beginning of their seizure. They'll seize. They'll sometimes be on the floor with that tonic-clonic movement the book talks about and all of the muscle twitching and muscle spasming. And once that ends and brain activity returns to normal, patient starts to wake up. But it's not just like pressing a button and your patient comes back to 100% clear and lucid consciousness. Your patient who's having a seizure or has had a seizure, as they're starting to wake up, they're in what's called the post-ictal phase. And that post-ictal phase really is an altered mental status. Their brain is only just coming back online. They're only just really beginning to oxygenate themselves and ventilate and move gases around. And they are really clinically altered at that point. What are some of the potential causes of altered mental status? Well, here we go. There are many, probably more than we could ever count or hope to even think of, but we're going to get into them. Our causes of altered mental status are anything from things that people do to themselves to things that just happen to them. Some of the big ones, alcohol or drugs, clearly those are going to produce some sort of altered mental status. That's what they're meant for. Epilepsy, we've talked seizure a little bit. We'll get into the nuts and bolts of seizure in just a couple of slides. Insulin, our diabetic patient. Think all the way back to chapter 6 and tell me, does the brain cells produce any energy when there's not enough sugar around? Will they switch to that anaerobic metabolism without oxygen and no sugar?
No.
No, they don't. So our patient who is hypoglycemic or low sugar in the blood is actually going to be profoundly altered. I'm a type 1 diabetic. Times that my blood sugar has been far too low, I have been significantly altered to the point of being unresponsive. And this is one of the main causes and one of the big things we can look at to try and figure out what was the cause of my patient's altered mental status. Hyperglycemia, or high sugar in the blood, can actually cause the same thing. I think tomorrow or Monday is the diabetes lecture, and we will talk about sort of the process that's going on where high blood sugar is going to cause some pretty negative effects on our patient. But any type of disruption to the body's ability to use the sugar that's supposed to be there, we're going to have some issues. Oxygen, well, we already just talked about if my patient doesn't have enough oxygen and doesn't have enough sugar, that their brain won't switch to that anaerobic metabolism. And if the brain won't switch to anaerobic metabolism, the brain's not going to create the energy that it needs to keep on braining. So from there on out, your patient is going to have some changes to their level of consciousness. Your patient is going to have some changes to their perception and their actions and the way that they do things and perceive the world. Why do you think kidney failure is on this list? Does anybody know what the kidney's job is?
Well, it filters
Detoxifies the blood.
can't necessarily keep in our bodies, and so when our kidneys can't filter, then it ends up in our bloodstream and it just affects us detrimentally.
Perfect. You guys are both right. Perfect track. Kidney's job is to filter, and it filters out toxins and it cleans out the blood and it makes everything nice and shiny and new. And if those kidneys aren't working, all those toxins that the kidneys are working to get out, back up and build up. And when the kidneys start to fail, well, we're going to have some problems with all of those toxins still being readily available for altered mental status to take hold. Now let's move on through the rest of them. Trauma. Why do we think traumatic events can cause some altered mental status?
Head injury.
So head injury for sure, right? When the old brain box is affected, a traumatic event to the brain is going to be a problem.
Blood loss.
Blood loss. Why would blood loss cause a problem?
Because there's not enough, like, again, I don't know how to explain. I just know that blood loss can alter a mental status, but I just don't know how to explain it. But
Because if there's not enough blood, then there's not enough oxygen.
Yeah, oxygen delivery and shock is going to be one of the things that we're on the lookout for with our trauma patient. And our trauma patient, if we go back to that that case study we did on shock just a little bit ago, it showed us our patient's mental status changing and altering, and he was becoming more and more profoundly altered, and things were changing for him mentally. Infection, well, that's going to go sort of along the same lines of shock, right? If the body is busy fighting off some sort of invader and trying to clear out this infection, and that infection is beginning to win, our patient will go septic. And if our patient goes septic, we have another shock situation. If we have another thing that causes shock for our patient, we're going to have problem with oxygen delivery, oxygen demand, sugar delivery, sugar demand, and that shock is actually going to cause altered mental status. If we look at all of the things on this list, a lot of it has to do with oxygen, toxins, or not having enough sugar, or not being able to actually, for the brain to support itself. Psychiatric problems, sure, they can cause altered mental status. It could be something quite as simple as somebody with an undiagnosed psychiatric condition, or it can be somebody with a diagnosed psychiatric condition who's having some profound changes or increased stressors. When we speak about psychiatric problems becoming an acute emergency for us, generally we lump them down as behavioral issues, but some of the times it is just an altered mental status from some other cause. Now, if we look at all the things on this list, we don't have to go through all of them. We've hit shock already. We've talked poisoning. We're going to get into stroke in just a minute. Look at this list, and it is far from an all-encompassing list. This is not everything that will cause an altered mental status. How on earth are we expected to figure all this out?
In your primary assessment?
So my answer to the question is actually probably going to be a bit relieving for you folks. In your primary assessment, sure. In our primary assessment, we're going to take care of all of the things that are going to keep this patient viable and upright and taking nourishment. Absolutely. But realistically, we don't have to figure all of this out. Now let's take a look at some of the things that are on this list that we can figure out or maybe even fix. If we show up and our patient smells like they just climbed out of a whiskey bottle, can we fix that?
No.
All right. If my patient is an epileptic and has a seizure history, and right now in front of me is postictal, is there anything I can do about them having a seizure?
No.
Not really. What about my diabetic patient whose blood sugar is really low? Can I figure that out?
Yes.
Yeah.
Can I fix it?
Glucose.
Yeah. 1 tube of oral glucose in the buccal membranes in their mouth between their cheek and their gums. And I want them to leave it there until it melts, and I don't want them to swallow it. We'll get into why we don't want them to swallow it tomorrow or Monday, whatever day that is. But we have a fix. We also have a machine that will tell me, is the cause of my patient's altered mental status because their blood sugar is low? I take a finger stick, I check their blood glucose, and if their blood glucose comes back as below 70 and they're symptomatic, guess what? I've found the culprit and I fixed the problem. Now, what about oxygen? Can we figure out how a lack of oxygen after our last lecture might cause my patient to be altered? I mean, we just spent almost 2 hours talking about respiratory anatomy, physiology, respiratory conditions. Can we assess a patient and figure out that maybe they're not breathing appropriately or the gas exchange isn't happening appropriately, and there's stuff that we can do for that?
Well, in general, could we say that a lack of resources to the brain could lead to an altered mental status? Electrolytes and oxygen cause altered mental status?
Sure. So what are some things that we would look for? We just went over evaluating a patient who's having respiratory distress. And we're saying that lack of oxygen can cause an altered mental status.
If they're like wheezing, chest isn't rising, their skin color.
Yeah, we evaluate what is my patient's respiratory status. Because as a general rule, unless you are having some form of respiratory problem, oxygen is probably not going to be your issue. So we evaluate during our breathing and during our assessment of this patient, are they moving enough gas? Do I have that good chest rise and fall? Do I hear any adventitious lung sounds? Do I have a respiratory rate that is improper, either too fast or too slow? So I've gotten rate, rhythm, quality. And then I see color in the chat room. So yeah, skin color, temperature, and condition. All of those things that we already know how to do are going to tell me, does my problem live here? Does my problem live here? Does my problem live here? And these are the things, all right, no problem. I can figure all of this out. I can get on about looking at all this stuff. If it's a result of a poisoning or a drug overdose, I have a medication to fix that. If I find out that this, yes, is in fact a narcotic or opiate overdose, and we start chipping away at the things we can evaluate, those hallmark signs and symptoms that we look for in a patient who has septic shock or hypovolemic shock or cardiogenic shock, or is having a respiratory issue like lung sounds and poor chest rise and fall. And we start working our way through the things that we know we can evaluate, treat, and figure out. And at the end of the day, if we get to the end of the list and we still don't know what's causing this patient's altered mental status, that's not a big deal, because we don't have the ability to do imaging. We don't have the ability to figure out every single thing that has ever happened to this patient, draw labs and do all of that stuff. So we work with what we got. I can evaluate this and I can treat this. I can evaluate this and I can treat this. If it was some sort of traumatic event, I can make sure that my patient doesn't get any worse. If they have sepsis, I can make sure I follow my protocol and do the things that I'm supposed to. If I see signs and symptoms of shock, I'm going to make sure that my patient is oxygenated appropriately. And when we talk about stroke, the American Heart Association used to call a brain attack. So when we talked about myocardial infarction and that being a heart attack, what we were talking about was death of the heart muscle from lack of perfusion. When we talk about stroke coming up here in just a few minutes, we're going to now talk about its nature as a brain attack and death of brain tissue due to lack of perfusion, and why and how that's going to cause some of that same altered mental status and some changes in the way that a patient behaves or presents, and things that we can do to make that better. We cannot figure out, nor can we solve the problem of what is actually going on with a lot of these altered mental status patients. But there are very specific things we need to look for. In the field as providers, even as far up as like doctors and nurses, people are often very, very quick to, the 25th time that they have showed up to Bob's house and Bob's been drunk and altered, to just say that the cause of their altered mental status is Bob being drunk. We need to, with altered mental status, since there are so many possible causes of altered mental status, we need to make sure that we have looked under the hood and checked for all the things that we can figure out before we just say, well, Bob's just drunk. Because what I'll tell you is drunk people fall down an awful lot. And if somebody falls down an awful lot, could they have a traumatic head injury? Might they have an infection? Might they be suffering from some sort of psychotic episode? Maybe their kidneys are failing. Maybe Bob, since, people that drink like that oftentimes probably smoke too, could Bob be having an oxygen problem or an insulin problem? If you didn't check, you don't know. One of the things that you need to get in the habit of going forward and as providers is any patient that presents to you with an altered mental status, check a blood glucose. Why do I say that? It's not like everyone who's altered is a diabetic, right?
Because anyone can get diabetes at any time too, so it might be their first episode.
Could be their first episode. How about just something as simple as, maybe it's not because they're hypoglycemic, but at least I can check something off my list. All right, I checked their blood sugar. Their blood sugar is 110, which is dead in the middle, perfect. So I know low blood sugar and high blood sugar are off the table. Neither one of those things is causing this altered mental status. So then I just checked something off and I can say, yep, I evaluated that. It is not the problem. And then I move on. All right, well, the patient's respiratory rate, rhythm, and quality are great. No adventitious lung sounds. Pulse oximetry reading is 98% on Romer, and they have no respiratory complaint. All right, is it likely to be oxygen that is the result of this patient's problem? Because I've evaluated all the oxygenation causes that could have presented, and I've looked at all the things, I can check oxygen off my list. And I've worked through my list of possibles until I get a working sort of differential. Okay, could be this, could be this. Looking at some of the things that are left on the list, there's not a whole lot I can do about it. And when we talk about stroke, one of the important things to consider with stroke is just like with a heart attack, time is brain tissue. So if your patient is having a stroke, getting on about it quick and figuring out that this is likely signs and symptoms of a stroke is going to mean that we will preserve more function for our patient if we're right. Because we do a couple of things, and it talks about this stroke scale. A stroke scale, they came up with a million of them. The minute somebody invented something, everybody went, oh, that's a great idea. I'm going to name it after me. I'm going to name it after them. I'm going to name it after my maiden aunt Sally. So there are stroke scales from Boston, Miami, Cincinnati, Los Angeles. And guess what? They all evaluate the same freaking thing. When we have a patient who is presenting to us with an altered mental status or signs and symptoms of a stroke, these are all the boxes that we have to check. We have to make sure it's not a hypoglycemic event. We have to make sure that my patient isn't likely to be experiencing a stroke or a cerebral vascular accident. We always want to make sure that we are checking sugars and getting a stroke scale. And we'll talk about what the stroke scale actually is. There's a new commercial on TV for it I've seen in the last couple of nights where they mention that FAST scale. That's legitimately what we do in the field. One of the big things with the elderly people is a UTI and altered mental status. So we have a known source of infection and an elderly person who is newly altered. And I mean altered to the point where I have seen elderly patients in a nursing home stab an aide with a pen or a pencil. And it was all because they were in septic shock from a UTI or a pneumonia, and it was causing them to have an altered mental status. See that same patient once they get better from the UTI or the pneumonia, they're the most pleasant person I ever dealt with. But I watched her physically assault someone.
In that case, who do you help first? The person that was stabbed or the psychotic?
She wasn't hurt bad. I mean, it wasn't like she stuck her with a butcher knife. It was like maybe something that needed a band-aid, if I remember correctly. It wasn't like she skewered her. Old people don't move that fast.
Oh, okay, I was just
So
out of curiosity.
yeah, I mean, sure, could it have been something? It could have, but it turned out to be, it was like she had like a scratch. It wasn't a big deal. I did almost get kicked by a hypoglycemic 85-year-old. Altered mental status is a weird call. So let's talk about seizure here for a minute. What is a seizure? Does anybody know? So the brain sends off these messages, and the messages that the brain sends is an electrical signal. Our neurologic system is run like the wiring for a car or the wiring for your house.
Wait, is it like a signal? a shot of electricity, but like it's not controllable.
Yeah, you're there. So the brain sends out all these electrical currents, and it's telling specific parts of your body to do specific things and carry out your task, and like Bill Belichick, do your job, right? And these messages are very, very regimented, very, very well organized. The brain is the motherboard of our entire person. It sends out all the messages to the everywhere and keeps everything filed and everything functioning and everything goes along smoothly. When a patient has a seizure or a seizure disorder, all of that function and all of that regimen and all of that everything going out the way that it's supposed to gets interrupted. And instead of having these nice, regular, easily understood messages for the rest of the body, the brain sends out all of these chaotic electrical signals that get crossed and mixed up. And that abnormal electrical activity coming from the brain causes the body to just pretty much hard reset. It can cause muscle contraction. It can cause the patient to just stop doing everything. It can cause everything from like an absence seizure, where the patient just stands there and stares at the wall for a minute, to the great big chaotic tonic-clonic seizure that we think of when we think of a typical seizure patient. This tonic-clonic seizure is normally preceded by sudden loss of consciousness and these chaotic muscle movements. This patient is constantly contracting, relaxing, and twitching and flopping on the floor. Generally, they last about 3 to 5 minutes. Generally, because sooner rather than later, the brain just resets itself. But if they last for that 3 to 5 minutes, what does it sound like probably isn't happening the way that it should during that 3 to 5 minutes?
Breathing.
Yeah, breathing. Your patient during this whole seizure period is not breathing. So when they start to wake up and we hit this postictal phase, they're altered from low oxygen. So what do you think our treatment for a seizure patient might be?
Oxygen.
First and foremost, once they stop seizing, or if you can get an oxygen mask onto them without hurting them while they are, we're going to provide for them oxygen. Generally, when we get to a seizure patient, we don't actually witness the seizure because it takes most of the time, even in a perfectly run system, 6 to 8 minutes before we're standing next to our patient. So we a lot of times will see that altered postictal phase where the patient's starting to wake up, and we don't see that tonic-clonic motion of them seizing and jerking around on the floor. We see a patient who's beginning to return to consciousness and starting to become more lucid and waking up a little bit, and we oxygenate them. But since they're altered, should we check a sugar?
Yes.
All right. Why would your seizure patient, who probably isn't a diabetic, benefit from you taking a blood sugar? Think of all those muscles everywhere in their entire body contracting and relaxing over and over and over again. What are they using a lot of when they do that?
A lot of energy.
A lot of energy, a lot of sugar, a lot of oxygen. This patient is likely to be pretty hypoxic and definitely in need of some oxygen. And this is all after the patient seizes. What do you think our treatment for a patient who is presently seizing when we get there might be? Is there anything we can do to stop them?
Putting them in the recovery position and just trying to keep their head.
Turn them to the side.
All right, so we're going to maintain an open airway, it seems like. I like the way that sounds. Put them in the recovery position, turn them to the side if we can. Realistically, our big focus for someone who is still seizing when we arrive on scene is to make sure they don't injure themselves any further than they already might have. So, try and prevent them from seizing their way down some stairs or knocking anything off of a table or a cot or knocking anything over on top of themselves, because they are on the floor completely unable to control anything that is going on with their body. So we are definitely looking at a patient who needs a bit of assistance as far as, hey, we can't allow them to hurt themselves. Don't let them keep like whopping their head off the floor. Try and put them in that recovery position. Try and hold their head up or put something underneath it so they don't continue to bash their head off the tile. So we talked about how our seizure patient generally isn't breathing while they're seizing. And then we said that most seizure patients generally aren't still seizing when we get there. If they are, we have found a patient having this going on. So this is one of the book definitions. This is something that you'll see again for sure. Status epilepticus is a prolonged seizure event that can last between 5 and 30 minutes and consists of 2 or more seizures in a row without regaining consciousness. So tell me again, what's not going on while this patient is seizing?
Breathing.
They're not breathing.
They're not breathing. And what's happening to this patient if they are continuing to seize for 30 minutes in a row?
They're losing blood volume.
They're losing oxygen to their brain, and they're also burning way more sugar than they would in just one seizure.
There you go. They're not really losing any blood volume because their blood's going to stay going round and round for a period of time anyway. But they are losing the ability to oxygenate their brain because they are not breathing appropriately or adequately to bring any of that oxygen in. They may aspirate, they may have a very uncontrolled airway. They can actually seize hard enough and long enough to fracture their bones. That muscle contraction gets to a point where they could actually break something. They are burning through whatever oxygen and glucose is still available in their body, and they can receive some pretty profound brain damage from hypoxia. And if they are burning through all of that oxygen and all of that sugar and creating all of this waste product and not bringing any oxygen in, but also using all that muscle energy, they can even become profoundly dehydrated from how much work it is to continue twitching those muscles over and over and over and over and over again for a solid half an hour. A patient who is in status epilepticus is legitimately a sick patient. You have your hands full if you have found somebody who has been seizing for an extended period of time, because sooner rather than later, they wind up running out of reserves. And once they've run out of those reserves, they are on borrowed time as far as being able to continue and get well, because their brain is becoming hypoxic. They're burning through all of that sugar. Their brain is becoming damaged. Their brain is becoming infarcted because it doesn't have enough oxygen left to create any energy. We got one last little thing to cover I need to bring up. Some slides so we can talk about stroke. And that will probably take us to the end of the road for lecture this morning. All right, here it is. Stroke is a term that is also referred to as a cerebrovascular accident. It is interruption to the blood flow of any portion of the brain. Strokes come in one of two functions. It's either an ischemic stroke or a hemorrhagic stroke. And what is actually going on past wherever this stroke is occurring is that brain tissue is beginning to become infarcted, just like a heart attack. And once that brain tissue dies, just like a heart attack, it's not coming back, and no longer will it do the job of actually working as a brain. So we have patients all the time who have strokes and they have interruptions in that blood flow to the brain, and we can actually do some good at making them better. It depends on what kind of stroke it is and how long it's been going on. Ischemic strokes are the far and away more common and more treatable. An ischemic stroke happens when a blood clot lodges itself in one of those cerebral arteries. So just like a heart attack, a blood clot gets lodged in a coronary artery. With an ischemic stroke, a blood clot gets lodged in a cerebral artery and interrupts blood flow to all of the rest of that piece of brain that's past where that clot is. And that clot is going to stay there and cause that brain to eventually no longer work. It's going to become infarcted. And once it becomes infarcted, that's it. Atherosclerosis and arteriosclerosis are two of the biggest contributing factors to stroke. And the other would be high blood pressure. People that have a history of high blood pressure or high cholesterol, a family history of stroke, something that we'll talk about in a few minutes are what's termed mini strokes or transient ischemic attacks. They're going to be patients who are at the highest risk for this to actually happen to them. And thankfully, our ischemic strokes can be corrected. They have all sorts of treatments now for a patient who's having an ischemic stroke. And they have the ability to go in and feed a catheter up into that cerebral artery and get that clot broken up and removed and open that artery back up so that blood flow will be restored. They have medicine that they can give that will actually go in through an IV and go up and dissolve that clot and get everything working the way that it's supposed to, and hopefully the brain function comes back. I want to ask you guys a question. Why do we give aspirin to a chest pain patient?
It prevents further clotting.
Okay, it prevents further clotting. I like it. We might get some blood past that blood clot in the coronary artery. So why don't we give it to stroke patients? It's not because of this kind of stroke. It's not because of the treatable ischemic style stroke. We don't give aspirin to stroke patients because of this right here. A hemorrhagic stroke happens when our patient has an aneurysm on one of those cerebral arteries that bursts. And when that aneurysm bursts and we now have a hemorrhage inside of our patient's skull, would we want to give this patient aspirin?
No.
No, because we would want that blood to stop. We would want that bleeding to cease and desist. So if we gave them aspirin, we would make this kind of stroke worse. There's no way in the field to really accurately determine whether or not your patient who's showing you signs and symptoms of a stroke is having an ischemic stroke or having a hemorrhagic stroke. So really, identification is where it's at for us with a stroke patient. In order to appropriately treat our patient who may be having a stroke, we do what's called a stroke scale. Now here we use the FAST scale with a couple of added little bits and pieces. So Anybody who's been into a doctor's office recently has probably seen that sign on the wall that says FAST in giant letters, and it shows an elderly person who's not able to do some things. And that's the exact same thing we're looking for. But instead of just fast, we want to be fast because time is brain. The B and the E in FAST stand for balance and eyes. Part of our assessment of someone who's having an altered mental status and we think could possibly be having a stroke, we want to ask them or evaluate, have they had any new sudden onset of problems with their ability to balance themselves or anything with their vision? Both of those things are controlled by the brain, and any one part of this assessment, if they do not pass it successfully, is an indication that they could be having a stroke. We're not diagnosing them with a stroke. We're just saying that they were unable to complete this list of tasks. So they have a problem with their balance. They have a problem with their eyes. The next part of our stroke assessment is going to be face. We're going to ask our patient to smile or stick their tongue out at us. And if they smile and one part of their face goes up like they were smiling and the other part just kind of hangs limp or makes a frowny face, that's a significant finding. That means one side of their brain is not functioning appropriate enough to send that nerve message off to make both sides of the face go up like they're supposed to. So we've gotten through the B, the E, and the F. The next part we're going to test for our stroke patient is their arms. We're going to have them put their arms out in front of them and close their eyes. We have the patient close their eyes for a very important reason. Your brain, if it's able to see something that it knows is wrong, can actually make your arm stay where it's supposed to. Generally, with a patient who is suffering or may be suffering from a stroke, when we have them put their arms out in front of them, close their eyes with their palms up, once they close their eyes, that arm all by itself rotates and drifts back down to their side. So we've gotten through B, E, F, and A. Now we're on to S, which stands for speech. Have them say something that's difficult to repeat. The sky is blue in Boston. She sells seashells down by the seashore. Something that's like a tongue twister. A patient who is possibly having a stroke is in no way, shape, or form going to be able to stumble their way through that. Remember, all of this stuff, fine motor, speech, balance, eyes, it's all controlled by the brain. Everything is controlled by the brain. We are doing so much neurological testing at this point with some very simple tasks. And the last part of the BFAST assessment, the T, time. We want to know the time this patient was last seen well, because there is a timetable for when they think they can restore perfusion. If your patient hasn't been seen well in a couple of days, well, they probably have now gotten to the point where these problems are going to be lifelong and they're not going to get corrected or get any better. If Bob's wife went to the store 15 minutes ago and Bob was normal, and you come in 20 minutes after that, and Bob flunks your stroke assessment but has a regular blood sugar, so we know some of the things that this could be and some of the things that this won't be, Bob is very likely to do okay because of the advancements they've made in the treatment of stroke. Our risk factors, this is going to be one of the big ones right here. A transient ischemic attack, or a quote mini stroke, is a patient who's having any of those stroke-like symptoms that we just talked about, but they improve on their own within 12 to 24 hours. This is absolutely a warning sign for a patient who is on the clock to have a real for life stroke. About 1/3 of people who experience these stroke-like symptoms and have them get better will experience a stroke in the coming months. Any patient who has these signs or symptoms of stroke that we've mentioned needs to be evaluated by a physician, because the only way to confirm that this isn't the real deal is through having some scans of their head done. So it's not anything we can pick out in the field. And they don't have to fail every single portion of this assessment. They don't have to get every single one of those things wrong. Each one is equally balanced. So just being unable to do one of the parts of your stroke assessment is a pertinent finding. If they fail the entire stroke assessment, for sure that's a pertinent finding. But if they only fail one, you may just have been lucky enough to find this patient prior to them having very, very negative signs and symptoms. And it's time to get on about bringing this patient to the closest appropriate facility with an ALS intercept en route. Because if we get this patient to a hospital, and I mean any hospital, I haven't been able to find one in the entire state of Massachusetts that couldn't start the beginning processes of treating a stroke patient, the prognosis for them is very good. The longer they wait and the longer it's been since the last time they were seen normal, the longer the road to recovery and possibly never recovering is a real for life probability for them. Isn't this doing stuff? All right. Anybody have any questions about today's lecture? Nobody? All right. So 5 after 11, you guys got a good enough beating with all this stuff today. So we're going to call it a wrap, and we will get caught up tomorrow. We'll do GI, GU, toxicology and psych from there. And we will be right back on the straight and narrow. I'll be at my desk until you guys get here at 1 o'clock. So if anybody comes up with any questions in the meantime, shoot me an email. Other than that, I'll see you guys at 1.
Quick question. What are we doing in class today?
We're going to be doing skills in class today.
Okay. Yes. I maybe I should have specified that more. Are we gonna do more case study work? Or are we actually moving towards a different skill today?
So we won't be doing any case study today. We're going to finish up going through cardiac arrest management station 1.
Okay, station 1. Okay.
We're going to work more on patient assessment because, let's see what we do today, respiratory. So now we have new things that we can treat and new signs and symptoms to be on the lookout for. And we may actually now be at a point where we can get into some group testing and do a little bit of almost like sort of EMS Jeopardy. Because the skills
so we could play like a game type. That would be kind of live. Jeopardy?
Sort of. Same idea anyway. I just don't have the time to make up 100 Jeopardy game boards when, well, we pay somebody to put that together for us. So
yeah, you could do it easily online.
We're going to do it on EMS testing because that's going to mimic our National Registry style questions. So once everybody gets done going through station 1 with me here in the classroom, we'll get into some of that kind of stuff, because getting the flow of the national exam is going to be worth its weight in gold.
Sound good to me.
All right, I'll see you guys all shortly.
Thank you.
No problem.
Thank you.